Thank you. Thank you. So I'm so happy to be here, and I want to thank the conference organizers for all the work that has gone into making this conference happen so smoothly and in such an interesting way. I'm going to talk about ACT and depression, but I'm going to talk about psilocybin-assisted therapy in a broader context too. I'm going to talk about two other studies that I've been involved in and some of the bigger sort of procedural and philosophical ideas about psychedelic therapy in the context of academic research. But more about that later. So I'm from NYU. I'm a psychoanalyst and psychiatrist in private practice in New York. I trained at the NYU postdoctoral program in psychotherapy and psychoanalysis. And this is my office. This is where I earn a living. I don't earn a living doing psychedelic therapy. I'm in New York City, and again, I'm affiliated with NYU, and the research that I do is with NYU mostly. Some of it is with Yale, but this is the setting for the research that we do. This is the research room that we have, our couch and our end table. It happens at Bellevue Hospital. This is a picture of the entrance to Bellevue Hospital. And again, this is all located in Manhattan, New York City. So my talk today is divided into three parts. The first, do we need a highly defined therapy for psychedelic research? Okay. And do we need a highly defined therapy for treating patients clinically? In other words, would a more general or more non-specific therapy do just as well, or do we need any therapy at all? That's the first section. The second section is a very brief review of the therapy platform that we used in the NYU Cancer Anxiety Study, which was completed in 2000 and or was published in 2016, and the ongoing psilocybin-assisted therapy for alcohol use disorder. I'm going to present a little bit about that. And then the third part, and the largest part, is a description of a therapy platform that we have developed at Yale. It has not been used with any individuals in the study yet. We have just enrolled the first person and had the first couple of sessions, but I'm going to present to you the ideas that we brought together on how to integrate ACT with psychedelic therapy. So, do we need a highly defined psychedelic therapy for our research and for treating our patients? My answer to that is yes. But I'm going to show you what I think of as the bigger picture of psychedelic use and psychedelic experience. There are many settings where psychedelics can be used in safe, meaningful, and integrative contexts. People can use them individually for recreation and for socialization. People can use psychedelics alone or with a sitter or in a group for spiritual development. This is a psychedelic psy-trance gathering in Goa, India. Really quite different context, a different expectation, a different preparation, and a place where psychedelics are used. This is an indigenous shamanic setting for the use of ayahuasca. This is Carlos Tanner, who works at the Ayahuasca Foundation. And I spent a couple of weeks with him a number of years ago in the very preliminary part of a shamanic training program, one that I didn't follow through, and I didn't follow through and do shamanic training with him, but he's a really, really great guy and a good teacher and healing person. This is a contemporary syncretic neo-shamanic settings. I tried to avoid having any pictures of any neo-shamans lest they be offended at not being considered shamans, and it's a very complicated question of who's a neo-shaman and what do neo-shamans do, and cultural appropriation, which itself is a big question. But there's a lot of psychedelics used in neo-shamanic settings. And this, as I'm sure many of you recognize, is the Santo Daime and the Native American church. We see the dresses for women. This is a Santo Daime church. And here is a row of parishioners in the church drinking ayahuasca as part of their religious ceremony. And this is their Christ symbol. And this is a teepee where a ceremony is occurring. And then we have Bellevue Hospital, which is in so many ways so different than all of these other settings. And yet, there it is. There is psychedelic healing, psychedelic therapy going on behind these gates in this room with these little bowls here. on First Avenue and 27th Street in New York. Here's some more pictures. This is the room made up with a volunteer posing as a patient. This is some tchotchkes that we have. Have been given many, many mushrooms. Now, in the previous slide, you saw a lot of people who were engaging in psychedelic use in safe, creative manner. And here we have the patients who come to see us. PTSD, alcoholism, depression, and cancer-related anxiety. So I included pictures like this in order to convey the way people present and the suffering that they present with when they come to us as psychiatrists, psychologists, and nurses. So there's this great deal of concentration and of misery, and they are organized by the nature of their misery. That's what the DSM-5 is. For all of the criticism that the DSM-5 takes, it's an attempt to find some way to organize the vast experience of human misery and categorize it in some way. And I know categorizing things, deprives them of something, but it also gives them something, and it allows a certain kind of approach. And we'll talk more about that later. Now, in these different ways of using psychedelics, there are 3 levels of responsibility for care. Self-care, you're on your own, you're tripping alone, you're in your home, you're in the woods, but you have to maintain self-vigilance and care for yourself. In a peer context, your friends, a colleague, a sitter is responsible for you, but they're your peer, and the responsibility that they hold is quite different than what a shaman or a psychiatrist, psychologist, social worker, somebody who's trained to care for the mentally ill would have. And so I'm going to lump doctors and shamans together as carrying a list of responsibilities that I don't think anyone else does. And this list has a lot to do with psychedelic therapy, because to be a psychedelic therapist, I believe you have to embody and carry out all of these elements, or these competencies. You have to have extensive training and apprenticeship, and that lasts years, not weeks. I often hear of 3-day psychedelic therapy trainings or 5-day psychedelic therapy trainings, and you cannot become a therapist in 3 days or 5 days or 3 weeks. If you're already a therapist, you can learn to integrate psychedelics in your therapeutic identity, but it takes years to become a psychiatrist, psychologist, psychotherapist, and shaman with an apprenticeship of treating cases and having supervision for them. So doctors and shamans have experience in treating people with that condition. They are responsible to select patients for treatment that come to them and say yes, no, maybe, later, which you don't always see in peer contexts. So they have to select a treatment for the patient. Not everybody who comes to a shaman in South America is given ayahuasca. They may be given flower baths or fasting or other kinds of interventions before they receive medicine. So selecting the treatment, preparing the patients for what's going to happen, running the treatment, identifying and correcting problems that arise during the treatment and after, maintaining the quality and security and safety of the medicine, although this involves pharmacists too in Western medicine. In the shamanic world, the shaman is a pharmacist who cooks the medicine and keeps it safe and prays over it and makes certain that it's that it's right for the work that he or she is trying to do. So doctors and shamans also are responsible for long-term care planning, recommending or discouraging repeat treatments, and other types of treatments, and also learning from experience, learning from mistakes, and going back and correcting what you do. Now, all of these things are not something you would expect from a peer counselor or monitor. They're something that you would expect from an experienced clinician who knows what to do and has a big picture of what the problem is. And if it sounds like I'm on a soapbox, I am a little bit, and that's because at various times in my work in this field, I have had to fight for the idea that psychedelic therapists should be trained therapists, because not everybody believes this and believe that they believe that a certain kind of person without any kind of therapy training or any work in mental health could be or would be safe to treat patients. And just to like hammer on this a little bit more. This is Ephraim Tori, who about 2 decades ago published this book, Witch Doctors and Psychiatrists, and he describes the sort of paradigm for healing that's universal all around the world. And I want to emphasize number 3, and number 4. The suffering is understood or narrated in a shared way between the sufferer and the healer. And this is one of the things that I think that there's a gap for somebody who might go to South America and have an experience, and the shaman's worldview and way of understanding is quite different than the North American who went there. So in that way, he had an indigenous experience, but also one that was exotic and foreign and did not have as much comprehensibility, because a shared narration between the sufferer and the healer is an essential part of the psychotherapeutic process working. So number 4, treatment happens, and the healer is in charge of keeping the treatment on track. Usually money or goods changes hands, and then the sufferer is changed, hopefully for the better. And then, and this is very important, the sufferer goes back into his or her community and is recognized as having been changed for the better. And then the reputation of the shaman or the psychiatrist goes up. And if the person goes back into the community and they're worse, then the reputation goes down. So there's a feedback loop between the community as a whole and the work that the therapist or shaman is doing. And again, this is what I consider psychedelic therapy. So here we are. I've already given my pitch about the much maligned DSM-5. And I'm not going to talk about PTSD today because I only have so much time, and I'm more intimately involved in the alcohol and major depressive disorder and cancer anxiety study. So I'm going to pass on that. Now, this is the paper that we published in 2016. And if you notice in the title, it's Rapid and Sustained Symptom Reduction Following Psilocybin Treatment for Anxiety and Depression. So symptom reduction is in the title of this paper. And it was, in a sense, necessary to get the paper published because there was a lot of concern over using the term existential distress. What is that? What is that? We don't know what that is. And the anxiety and depression reduction were the most clearly found objective points or findings that could be published and noted. So this is the group: Steve Ross, who's here and going to present tomorrow, Tony Bassis, Gabby Agan-Liebes, Crystalia Colionci, Alex Belser, here, Tara Malone, and John Rosen. This is our core team that contributed to this study. Now, this study, when it was formulated, was about existential distress in reaction to a cancer diagnosis. This study was not about the terminally ill, even though no matter how many times we explained that it's not for the terminally ill, people still love the idea that this is a study of people who are terminally ill. It's not. It was a study of people who were frightened and had existential distress in reaction to cancer. And some of them were free of cancer, but they still were preoccupied with the idea of a relapse and having cancer. So this is Virginia Lee, and existential distress is pain that results from the very foundations of life. Losing a sense of the foundations of your life, whether life has any meaning, whether life has any purpose or value. So existential distress is an anguished thought about non-existence, being dead, losing purpose in life, and a loss of meaning in life. So David Kassane, who writes on this, said that targeted therapies must aim to explore and restore meaning and hope within the context of advancing disease and impending death. So you don't see a reduction in anxiety or depression symptoms here in this definition. And in fact, SSRIs and anti-anxiety agents are not considered to be terribly effective treatment for existential anxiety in reaction to a cancer diagnosis. So our therapy focused on meaning making. And when I heard this, I thought, well, what is meaning making? Doesn't everybody, isn't every therapist make meaning? Isn't that the only thing we do? And with study, I came to discover that meaning making is a very specific way of listening and responding to patients, and that there's actually quite a lot of writing about loss of meaning and meaning making in the existential therapy world. We first studied Viktor Frankl and logotherapy, who wrote this book, who wrote the book Man's Search for Meaning, not long after escaping from a concentration camp. His philosophy of therapy has meaning at the center, that life has meaning under all circumstances, even the most miserable ones. He discovered that people who could retain meaning while in the camp survived longer and lived better. Somebody adopted a rat and fed it every day. And this relationship was healing as opposed to the despair of facing a probable death and loss of loved ones and freezing to death. According to Frankl, we can discover meaning in 3 different ways: by creating a work, experiencing something, or the attitude we take. So let me take a moment here to say that I was the director of psychedelic therapy training for this project, and we trained therapists 3 or 4 times. We had our initial cohort, and then we trained 3 or 4 more times. So when you're a training director, you're always thinking, how am I going to teach this? How am I going to teach this to people? How will I know if they're getting it? What do we really want to teach as the skills that are necessary to do meaning-making therapy? And surprisingly, there is a lot of writing about this. Now, I didn't find this until after we finished our study, but this is a meaning-centered workbook that is based on Viktor Frankl's logotherapy and existential analysis. And I have this book, and if we ever do another cancer anxiety study, we're going to work with this workbook for the therapists to learn how meaning-making works, because that's the core idea in this therapy for this population. We also used individual meaning-centered therapy for advanced cancer patients by Bill Breitbart and Sharon Popito, and especially these 3 chapters about attitude, creative sources of meaning, and experiential sources of meaning. So these are really practical ideas. Even though it may sound kind of undefined and woofy, it's not. There's a lot to learn in meaning-making, and that was our deal. And this, I want to go through this quickly. This is something that we did in the 2nd session. This is a life review. On the left is birth, on the right is death. Wherever the patient decides to put cancer is there, and now is now. And we go through and listen to the patient describe what's been meaningful, what's been important, what losses they've faced. And as you listen, it's very easy to hear how that patient makes meaning and how cancer has lost or robbed them of meaning. And then on the right, what they want to do before their death with the rest of their life. And interestingly, all on the left is what the patient wrote, and on the right are things that I wrote because he became so animated talking about his life and the things that he wanted to do. And this is a close-up, and you can see that it wasn't factual as much as his experience of one moment or another. Doing well in school, I was mean to Scott, I didn't make friends quickly, I was shy around girls. All of these came to be his story and the narrative of meaning in his life. Okay, so we're going to leave the cancer anxiety study now and move to the alcoholism study. This is a study that Michael Bogenschutz at the top and Alyssa Forsheims did at University of New Mexico, a proof of concept study on alcohol-assisted treatment for alcohol dependence. Psilocybin-assisted treatment for alcohol dependence. And this study is going on now at NYU, and we have Elizabeth Nielsen, Steve again, Sarah Menenga, and again at the bottom row, Sam Povrabarak, Lindsay Owen, Jesse Duane, myself, and Kelly O'Donnell has joined this study, but I couldn't find a picture of her to put here. But she's a therapist and study physician here too. Out of that work, and in preparing for the current study, they developed a treatment manual, and if you're interested, they have a lovely paper called Development of a Psychotherapeutic Model for Alcoholism, for a psilocybin treatment of alcoholism. This is meta, the motivation, enhancement, and taking action. So this is the cognitive, behaviorally oriented part of the treatment, and this is a preparation, support, and integration. We use a workbook called STORK, which stands for the situation, thoughts, organic response, organic patterns, responses, and consequences. So anybody who's done addiction work will recognize this as a way to do relapse prevention. It's very standard work. So there was no concern about having this well-known successful therapy done with psilocybin treatment. Also part of this is a card sort in which you look at the values that the individual has and ask where, when, how those values got lost from alcohol and how they're going to be restored in sobriety. So it's a guideline for getting to know the patient in a really deep way relatively quickly, and they're the ones that are picking these values for themselves. Okay, rushing through, we're going to go to the major depressive disorder. And I wanted to include these gifts because I think that they really remind us how much pain and suffering and anguish these patients have. And especially when they're in our study, they have to be off their medication, which can leave them in a very painful, raw state. So they're really quite vulnerable people. And they've had a long history, usually, of inadequate treatment with medication, or inadequate response to treatment with medication. So the study is called Psilocybin-Induced Neuroplasticity in the Treatment of Major Depressive Disorder. So this is Cyril D'Souza, who's the PI of the study. And initially, he did not want to have any psychotherapy in this study at all. And he wanted it to be free of any interference with looking at what psilocybin did to the brain in depressed patients. These are the co-PIs of the study, Ryan Wallace, Jordan Sloshauer, and Rob Krause is the chief therapist in the study. This is Connecticut, New Haven in the US. And this is the manual that we wrote for treating people in the study. And with a lot of work, we managed to find a way to put ACT therapy into this study and still keep the framework of the kind of neuroscience-based research that he wanted, that Dr. D'Souza wanted. So there were 9 sessions, 2 dosing sessions. So our first battle was opposition to there being any therapy at all. Why not use a pure psychopharm approach? And we had a lot of reasons that we felt a pure psychopharm approach would be wrong for patients with depression. In the biomedical model for depression, the effects of psilocybin and all antidepressants are understood in terms of the neurotransmitters, brain systems that are activated or suppressed. In other words, a broken brain is going to be repaired with a special medication. In this setting, the doctor is the one who is knowing and powerful and the one who is solely in control of the treatment process. The medicine and the doctor are idealized as powerful and as responsible for what happens, although perhaps in the case of people who have had treatment-resistant depression, the doctor and the medicine are receiving a negative transference, fear, mistrust, anger, disappointment at what doctors haven't succeeded in doing or what medicine hasn't succeeded in doing. But people come to psychedelic therapy usually with a highly idealized hope that this medicine alone is going to transform them. And so this biomedical narrative locates the problem in the patient's brain, which is an inaccessible part of their body to themselves. Their mind they have access to, but their brain, the medicine is the thing that's going to go there in a magical way. And this the ideal patient in this story is passive, compliant, obedient, and also very grateful for the brain-correcting medication. In session 2, we explain the situation to the participant, saying that he needs to be, or she needs to be, or is invited to be, a more active agent in changing his or her patterns of thinking and behaving. And it's the experience of the medication and the relationship with the therapist that are going to be used to facilitate changes in thinking and behaving. And that while the medicine may have a profound effect on eliciting these changes, it will not accomplish it for you. And the therapist communicates that active utilization of the medicine experience and the therapy, or ACT, is what's going to bring about change. When we were contemplating what therapy we were going to use, we considered interpersonal therapy of Myrna Weissman and Jerry Klerman. We looked at logotherapy, again, and mindfulness-based cognitive therapy. But the clear winner, after much deliberation, was acceptance and commitment therapy. And these are the two texts that we studied by Robert Zettel, ACT for Depression. And if you're interested in ACT and don't know much about it, I recommend ACT Made Simple first, because it's a much easier book to read. But the main guy of ACT is Stephen Hayes. And he developed ACT in 1982. And it's based in relational frame theory, which I don't really understand very well, so I can't really explain it to you, but it has to do with everything being connected to everything, and things in and of themselves don't have meaning except in how they are related to the context in which they exist. This is also known as third wave CBT, along with dialectical behavior therapy. It differs from CBT, traditional CBT, in that it does not seek to help patients control or eliminate their painful thoughts, their feelings or sensations, and they call these private events. It encourages acceptance, engaging with them, noticing them, especially the ones that are most painful and unwanted. And we've heard a couple of times today about experiential avoidance, and we're going to hear a little bit more about that later. Depressed patients will avoid thinking about things that might cause pain or anxiety, avoid doing things that might cause pain or anxiety, and while these are relieving of distress in the short run, in the long run, they create and redouble the problem. So encouraging being with painful and unwanted feelings, if those come up, is part of ACT, and as everyone here knows, that's an essential, central part of the advice that we give to people who are having a psychedelic journey, to be present, to be with, to not run away from things that are painful and difficult. So this is one of the many ways that ACT and psychedelic experience, as we encourage people to have it, overlap. ACT discourages involvement with personal history narratives. Why I'm depressed, what happened to me. The ACT line on this is, those things may be true, but they're not useful. They're not workable in the sense that they don't contribute anything to getting better. In fact, they give an explanation for continuing in the same pattern as before. So telling a story of what happened, while it may be very, very powerful and meaningful in a patient who's had trauma, in the ACT approach to depression, you want to steer somebody away from that, especially if it's a very well-rehearsed story that they've told 100 times. And no matter how important it may seem, a therapeutic intervention might be, well, there's that story again. That story is coming up now. Again, we've heard that before. It's like a behavior that your mind is doing, rather than engaging with the content of it. And ACT discourages a goal of feeling better and relief of depressive symptoms as the goal. So in this way, it's quite the opposite of a traditional psychiatric model for antidepressant treatment. Antidepressant treatment promises that depressed feelings will go away, depressed cognitions will go away, and you'll be transformed just by taking this medicine. And in ACT, the goal of feeling better is sort of like given a back seat. Instead, having a vital, values-driven life is the goal of treatment. So in some ways, it's like a pain clinic in which you don't promise that the person is going to be free of pain, but you promise that you can help them have a richer life, a more active life, a more pleasurable life, and learn to live with their pain better and have a better life. ACT is called a transdiagnostic process, which means it can be useful for anxiety, for depression, for substance use disorders. And that's because psychological inflexibility and psychological flexibility are the that's the essential nature of an ACT problem, and psychological flexibility is what ACT works towards. And you can see that kind of inflexibility in OCD, in depression, and anxiety, and a variety of other disorders. And so ACT, Hayes says, I don't like to say that we're treating depression with ACT. What he says is we're working with human beings who have depression using the principles of ACT to help them live fuller lives, which is a subtle distinction, but I think one worth really thinking about. So this is familiar to everyone by now, the ACT Hexaflex. And rather than go over it here, I'm going to go to something I've prepared to go through it one step at a time. And I'm going to go through this quickly because you've been exposed to the ACT Hexaflex today. The first is experiential avoidance, that is, not doing things, not seeing people, or internal avoidance, not thinking about things and avoiding things. And this is the source of depression rather than being a self-healing process. It's a self-perpetuating process for the problem. And the antidote, or the treatment, or the ACT healing direction is acceptance and willingness. Willingness to feel uncomfortable, willingness to do uncomfortable things, willingness to see things that you don't like seeing. Next, cognitive fusion. This is believing a thought. I'm a piece of garbage is examined as a belief that you can hear and believe and accept as true and do a bunch of things as if that's true. And that's the way that the thought has an impact on how you manage your life and the world around you. Cognitive fusion says that's just a thought. It's not necessarily true, and it's not necessarily false. Its trueness or falseness doesn't really matter as much as it is a cloud going across the sky that will be gone, and you don't have to latch onto it. And latching onto thoughts as if they're true is something that defines cognitive fusion. Letting go of thoughts as if they're just passing clouds in the sky is part of meditation, and of course it's what we hope people will do during a psychedelic experience. And it leads to diffusion. An example of fusion is responding to an actual needle and an imagined needle as if they are exactly the same thing. And if you look at theory of ACT in a really deep way, they talk about the transience of language and how I'm sad becomes equivalent to actually being sad. And that this is a problem, and that human beings do this because it's convenient and it helps us cope and live. But in depression, it becomes kind of paralyzing because thinking I'm sad and being sad become linked, and then you want to avoid both of those, and the thought becomes the affect. And so breaking these bonds is an important part of ACT. It's just a thought. Okay, so attachment to the self-story. I am this, I am that, I believe this, I am this tall, I am in Stockholm. All of these ways that we create an identity for ourselves is the self-story. And the antidote for that is the flexible self, but I like to call it the transcendent self. It's the transcendent self in that it says, I am not the thought that I have. I am not this label that I have for myself. And I think that this is a really common part of meditation, psychology, and psychedelic healing, in the sense that I am greater than the thoughts that I have or the small identity that I have. And practicing this from being too attached to your self-story and developing the transcendent self is something that you can work on with your patients in ACT. Sorry, I can't do anything. And the goal of this is not changing to, well, I guess I can do some things right. The goal is to change the relationship that this private event, I'm sorry I can't do anything, that this private event has to the patient's outside life and pattern of living. So the patient can have, sorry, I can't do anything right. And at the same time, cook dinner, go to the store, pick up her kids from the daycare, and live in a better way. So this is a way of working with these thoughts. And this is just another example of how the house has all of this furniture, all of these people saying things, depressive thoughts, painful memories. And around it is the transcendent self that is not harmed and that is always existing. And if you only think of what's happening inside, then you have no awareness of the transcendent self. ACT and psychedelics can bring them together. So dominance of the past and future, this is something I think we're all familiar with, thinking about the past, thinking about the future, not living in the present. And the ACT remedy is being in the present moment. Lack of clarity and contact with values. This happens in many patients with depression. They lose track of friends, family, hobbies, things that matter to them, and values that they held that helped organize, give their behavior meaning. And you clarify and help the patient get contact with their values, and we'll talk about how you do that in a little bit. And the last on the Hexaflex is inaction, impulsivity, and avoidance. That's not doing things. That's staying home. That's not doing something, and then doing something impulsively that's not really in line with your values and doesn't really contribute to a more meaningful, more well-lived life. And the solution for that is committed actions. Now, I like this when I found it on Google because it was just scribbled. It looked like it was written on a napkin. And it brings ACT down to 6 words. It's by Kevin Polk. Acceptance and diffusion are let go. The present moment and self as context show up. And committed action and values get moving. And this is ACT brought down to 3 words. Be open, be aware, and be engaged. I've tried to bring this paper to you by Stephen Hayes on Buddhism and acceptance and commitment therapy in a series of sound bites, but they seemed either overly complicated or trivial. But if you're interested in ACT and interested in meditation, I recommend this paper to you highly. And so I'm going to have to punt and go to the 4 Noble Truths. The second and the third one, that is. Because we don't have what we want, we suffer and feel upset. If we can accept what we have and stop wanting more, we will become happy. So in so many ways, this captures the many points of the ACT Hexaflex model with the addition of this point from the Eightfold Path, right action. So now I'm going to finish up by talking about what we do in the sessions. Not one by one, but in general, the beginning, dosing sessions, and then the end. First, we try to understand the patient's lived experience of depression and their depression treatment. Not the drugs that they've been on and how much, but what it's been like to be on so many drugs and what their relationship is to pharmacology and their fantasies and hopes about taking psilocybin. But in these first sessions, you're listening for patterns of psychological inflexibility, and you have to frame feedback to the patient in those terms. Now, depressed patients in many ways say a lot of the same things. I'm no good, I can't get up, I'm tired, I wish I were dead, nothing's any good, I've always been a loser. And so what they say is not terribly unique, and in fact it feels constricting and kind of exhausting to listen to them for long periods of time. So when you work with them in this way, you're listening for the ACT, what we call the ACT misdemeanors. Where is their experiential avoidance? Where is their fusion? Where is there a loss of values? And I'm assuming that different therapists will hear different things in the same, from the same person, because hearing ACT problems or psychological inflexibility problems and organizing that as a therapist and then saying something back to the patient in a way that's tactful and helpful and that they're ready to hear, I think is an art. It's something that you need experience in doing. And it's a way of speaking that's based on a certain kind of listening. And that is the main thing that the therapists are doing. So you want to notice attachment to reason giving and cognitive fusion. Reason giving is, oh, this happened to me and it's because my mother died when I was 6, and then I had to go to my aunt's to live and she beat me, and when I went to school I only had one pair of clothes to wear. And so these stories that are used to say why I'm depressed, you don't want to invite more of that story, because telling that story is not therapeutic in the ACT model. So in some ways it's quite the opposite of what we're learning to do in trauma work. In trauma work, we're encouraging people to go deeper and deeper into their core narrative of how they were harmed in the past. So this is quite the opposite. So you want to listen for their fantasies of psychedelic therapy and the expectation of magical cure, and education about the biomedical model versus the psychedelic model for therapy, in which they're expected to do a certain amount of psychological work and even some homework, and education about the need for collaboration. So during that, those first few sessions, the therapist gives feedback that is framed in identifying psychological inflexibility and alternate paths towards enhanced flexibility. So although you're not saying, well, you're doing this wrong, you would give feedback and respond in ways that guide toward psychological flexibility. And then you see what the patient does. And if you go someplace and something else happens, then you know that they're not ready to go there. If you start talking about values and a bunch of fusion comes up, then you've learned that you need to work on fusion first. You certainly can't go into activity first, because then you're going to see a bunch of other reasons, explanations of why that can't happen. So I think it's a therapeutic skill and therapeutic tact that helps the therapist find not only where the person needs to be in terms of their conversation with you, but also where they can be, where they can tolerate being with you. Another piece of didactic explanation that you do is differentiating willingness from desire. Desire, I don't want to go to the gym. Willingness would say, I don't want to go to the gym, but I can, and I will, even though I don't want to. Whereas like a more biomedical model would say, if you are well treated for your depression, you will want to go to the gym, and because it's going to give you, enhance your motivation. The message in ACT is quite different from that. So the dosing sessions are really not much worth presenting on here to this group, because they are the standard dosing instructions that most people use. Eye shades, headphones, Mendel Kahlen selected playlist, everything you'd want in a session. So in the debriefing and integration sessions, you pay attention to 2 or 3 points on the Hexaflex model. Generally, you don't try to talk about all 6 of them. You try to figure out which ones you think are going to be most meaningful and most accepted, and you work on them. And after the dosing session, you start doing some explicit education about the ACT model for how it works and what you expect from the patient. Now, before they started, before they started seeing the therapist, when they were still being consented in their preparatory work, they completed a valued living questionnaire, which was the best values questionnaire that we could find. And after the first dosing session, you bring this out and start working with them on values and action. Now, a value is something that you think is important in life and that you could do forever, like be kind to my children or study French. An action is meet with my kids every week to go to the zoo and hire a French tutor and buy a book, and that's an action. So values you never complete. Values never go away, but actions can be completed. And so you have to have values before you have actions, because if you have too many actions that you don't value, it's not going to do anything for your depression. The idea in ACT is that value-based action creates a richer, more full life. So why combine ACT with psychedelic therapy? There's many things that overlap between the two of them. Both focus on being in the present moment as an essential part of transformation. Both focus on developing a self as context, aka the transcendent self. And the ACT misdemeanor version of self as context is self as content. I am my thoughts. I am the idea that I have about myself. As opposed to, that's just something in here, and there's something around it that's bigger, and that is the transcendent self. Both ACT and psychedelic therapy encourage a radical acceptance of all thoughts and feelings as a path of transformation, rather than trying to escape thoughts or control them or make them go away. Both bring about a diffusion from, or disidentification from mental contents as absolute reality. Diffusion, which is transcendence. I am more than my cancer, my thoughts, my feelings. This is something that we saw in the cancer study very poignantly. When people would come in, we'd say, tell us about yourself. They would say, this is my cancer, this is my chemo, this is my chemo doctor, and these are my tumor markers. And that's their identity. Their identity had been shrunk to their relationship to cancer. And after treatment, you would hear, my cancer just wasn't so central to me. It's a part of me, but I'm so much more than that. And this is the transcendent self emerging. And lastly, many people in psychedelic experiences have a deep, deep resonance with what is true, what is important, what is valued, what really matters to them. And this is certainly part of ACT. ACT gives a template for the psychedelic therapist to work with. One of the things that I like so much about ACT is that it's very clear and specific, but it is extremely variable from one person to another. How you would work with one person may be quite different than how you'd work with another, and yet there's this underlying organizing principle that I think can meet anybody with depression in a meaningful way. It offers a specific set of processes to go from psychological inflexibility to flexibility, and I think that this can be a very interesting research question in terms of does that really happen, and what is the correlation between improvement of depression symptoms and changes in psychological flexibility? It interrupts the passive reliance on an idealized drug to make it go away, and at first, ACT is the setting. It's what the therapists bring, and then eventually, as the treatment proceeds, it becomes the set. That is, it becomes something that the person brings to themselves, a set of skills of thinking about behavior and thinking about thoughts that travel with them. So it's flexible and individualized, but it's still very specific, and it's also teachable. So psilocybin, what can psilocybin do? It may help ACT practices become possible. It may help them become much more deeply felt and more meaningful, because I can imagine that a really severely depressed patient would have a hard time really letting ACT practices in. And I think that there could be a very powerful interaction between psilocybin and ACT in terms of one helping the other be powerful. And ACT may help the psilocybin experience become learned and useful in a very practical way. So we often get the question, how can I continue feeling this way? How can I continue this afterwards? And usually the answer is journal, take yoga, be kind to yourself. So there's these very non-specific ways that we encourage people to continue what's happening in their progress. And I think ACT can offer people who have a lifetime of depression something that they can work with over the long haul in terms of getting better and better and better. So in summary, ACT helps the depressed patient to let go and be in the present and find values and get moving. And psilocybin offers the patient enhanced cognitive flexibility, increased tolerance of affect and self-acceptance, emergence of deeply held values, and an expansive transcendent experience in which to be free to try out and practice ACT principles, and increased self-efficacy. So ACT and the program that we put together here is, I think, quite secular and humanist in origin. It doesn't have an inner healer in it. It doesn't have a place for or a need for a lot of spirituality in it, but it doesn't prevent them. So ACT does not require you to believe in spirit or something outside yourself, but there's room for it if that becomes up for that person. And it doesn't depend on an inner healer, but it makes room for it. And it doesn't require a spiritual or mystical narrative, but there is room for it. It's very deep in its coherence and unity, but it can be quite different for different people. And it focuses on the very specific disorder that we're treating, major depressive disorder, and it offers a model for how these two interventions might have synergy with one another. So this is the clinicaltrials.gov for the study. I'm bringing it up again to say that we are recruiting. We have enrolled our first patient, and if you know anybody in the Yale, New Haven area who has depression and would like to be in the study, this is the guy to write. And with that, I want to thank you. Good. Yeah.